So we've got a large crowd this morning. I think we can get started
Yes, yes.
if you will permit me. And I'd like to offer everybody a good morning and a thank you for taking the time to share with us this morning. Our topic session is entitled Understanding and Supporting Children with Complex Developmental Trauma. So we know that children who have experienced neglect, loss, or interrupted attachments can often carry the deep and lasting effects of complex developmental trauma into nearly every aspect of their lives. And these early adversities may alter how they see themselves and the world, their emotions, their behaviors, in ways that reflect both their attempts to survive and their unmet needs for safety and connection. Guiding us through the session today is Maude Champagne. And Maude brings extensive clinical research and personal experiences to Interwoven Connections. She is the mother of 5 children through birth and
Mhm.
adoption, and her children who were older adoptees when they became a family. Maude has a Ph.D. in Neurosciences from Queen's University with a specialty in fetal alcohol spectrum disorder, trauma, and aggression towards family and caregivers in childhood and adolescence. She's also a registered social worker and psychotherapist and completed her MSW with a thesis on the experience of parents raising children with FASD and complex developmental trauma while undergoing dyadic developmental psychotherapy. In the past, Maude was closely involved with the implementation of the FASD Keyworker Program in Vancouver and the FASD Worker Program in Ottawa. She is a sought after expert and bilingual speaker for related trainings and conferences with a passion for sharing ideas, strategies, and resources that support families. And may I add, she's got a brilliant sense of humor. So before I hand things over to Maude, and since we are joining from all parts of the province this morning, Interwoven recognizes that its work and the work of its community partners takes place on traditional Indigenous territories across the province. We acknowledge that there are 46 treaties and other agreements that cover the territory that we now call Ontario. We are thankful to the First Nations, the Métis, Inuit people who have cared for these territories. And Interwoven Connections would also like to acknowledge the original stewardship of the lands from which I am broadcasting here in Toronto, in the traditional and treaty territory of the Mississaugas of the Credit, the Michisaawag, and the Anishinaabeg, who also we also acknowledge that the area is home to the Chippewa, the Haudenosaunee, and the Wendat peoples. Your questions can be put into the chat. It will be monitored throughout the presentation, and we have set aside some time afterwards for a Q&A. So now, I invite you to settle in, take a deep breath, and give yourself permission to be present because we are so glad you are here to join us today. Let's begin. Maude, over to you.
Thank you. Thank you for the introduction. And thank you for t talking about my humor because I think in these spaces, people that think I'm very, very serious person, but I'm not. But this is a serious topic. So, not to make too many jokes. So thank you for coming. I'm so happy we're such an interest in this topic. I think I realized that there's so many training on, when we adopt, on adoption, and then there's training on fetal alcohol spectrum disorder, FASD, and like different, even attachment, but we're not talking as much about developmental trauma or complex trauma, which is the same thing, it's just a different name. Um, and how can we make sense of like, okay, is it like a brain-based disability because of the prenatal exposure to drug and alcohol? Is it attachment? Is it the trauma? So this is what we're going to try to make sense of today. I don't have all the answers. I have some because I've done like my education on this topic, and also because I'm a parent. So sometimes I will answer based on science, based on what I've learned in my master degree and PhD from the literature, and sometimes I may also answer based on my experience as a caregiver and as a therapist. So I bring to this, many hats, and I hope that um, what you're getting from this webinar is not just like um, the feeling, oh, this is such a big mountain to climb, but also like there's strategies that you can use. There's hope. And it's also a matter of rethinking what we hope for. Do we hope for healing? Do we hope for secure attachment? What do we hope for? And what can I do as a professional or as a caregiver? And I also know that many of us are both professionals and caregiver in this space. If it's too much, please reach out for support to your IPC, to someone who understands your experience. The first part of the webinar, I'll be talking a lot about the problems, the things that we may struggle with our children. And then the last part of the webinar will be more about some of the solutions. Someone said that the chat's disabled, so I don't know if Francis or Courtney can check if the chat is workable. I am open to questions. Any questions you have, please ask. If you're too shy, just say it's for a friend. This is what I do, like asking for a friend and just ask a question. That's fine.
My
Uh,
mistake, Mode. I said chat. Put the questions, if folks are able, into the Q&A button
okay, you
at the
prefer the
bottom.
Q&A. Okay,
Yes,
that's
that's
fine.
where it's going. Thank you.
Yeah. And I will check the questions from time to time. I will answer live the questions that are related to the content. And then in writing, we will answer questions that are more related to, let's say, is it recorded and things like that. So let's start. I'm going to share my PowerPoint. Is everyone able to see my slide? I hope so. Rondola, please stop me if you're not seeing my slide. Okay,
Looks good.
so let's go ahead.
Looks good.
Okay, thank you. Okay, so let's start here, okay? What's the difference between trauma and complex developmental trauma? Okay, if I say developmental trauma or if I say complex trauma, we usually in our field mean the same thing. The big difference is now with adults, some psychologists will use the term complex trauma. Okay, but when we're talking about children, complex developmental trauma is the same thing, and that's usually the name we go for now. We have a manual to diagnose mental health issues, and it's called the DSM. It's not in the DSM, so it's not a diagnosis. Post-traumatic stress disorder is in the manual, but we have guidelines that were developed to define what is complex trauma. So from now, I'm just going to use the term complex trauma because it's just easier. And there's a big difference between what we mean by complex trauma and PTSD, post-traumatic stress disorder, or trauma in general. So let's say I have a daughter that I had through birth. She's developing well. She's 12 and she has a car accident with me and she breaks her arm. It's traumatic. Okay, so maybe, it was very scary to her. Maybe she'll have PTSD, but it won't change the way her brain is shaped. It's not necessarily going to shape her idea of what the world looks like, of what to expect in the world. It's not going to be affecting the trust she has in adults. It's not going to affect her attachment patterns. But if you have a child who has complex trauma, what we mean is not one or two events. We're talking about several traumatic events, and usually they involve interpersonal relationship. So was it the mother, the father, the uncle, even like the gym teacher that they have the relationship with, a cousin, and we're talking about very often abuse and neglect. And what you have to remember, it's within the context of a relationship. This is why it will impact several areas of their development, like attachment, like their learning, um, the way they make sense of the world, how they're able to trust others, what they think of themselves. And this is not what you have when you're talking about PTSD versus complex trauma. If you have one thing to remember from this is the brain development is quite impacted by complex trauma in many different ways, and it's different for everyone. Okay, everyone who has complex trauma will be impacted different in different ways, and it's a spectrum, right? It could be like they could be really, really impacted or not, and it's not always the severity or the amount of event that will make a difference in how they're impacted. And it's these aspects are usually um, happening in crucial developmental stage, especially if, like, let's say the child just got puberty and then they have sexual abuse, things like that. It could really impact more the individual. So it's really thinking about when these events have happened. It's also not the same as if you are an adult. You have secure attachment, you have, fairly decent life, and then something happens to you. You don't have the same resilience as someone who's a child and is developing um, their belief system, they're developing their attachment, their relationship with others. So the impact's not the same. And the main thing about complex trauma is it's really interfering with their ability to manage their emotions. That's the biggest piece. How do I deal with anger, disappointment? How do I deal with failure, maybe? How do I deal with someone who says no to me? Can I trust others? Can I expect that they will be there for me and if I need them? This is what is really impacted by complex trauma. It also really disrupts the attachment relationship that they may have with their caregivers. And sometimes we try to make sense of, like, okay, is it attachment? Is it trauma? But it's too intertwined. You can't really figure out what came first. And it doesn't really matter, to be honest. And that's what you'll see throughout the presentation. You might be like, oh yeah, my child or the children that I see in my practice are impacted in this area. And this is impacted based on maybe the trauma, maybe some of the attachment relationship that they had in the past, or maybe that's a prenatal exposure to drugs and alcohol. Doesn't really matter the cause sometimes, but it matters what we do in response. So, and I realize that when I share like this, I don't see the chat. So Rondola, please, if you see any Q&A that's relevant to the content, please stop me and I'll answer because I don't see them from this mode of presentation on Canva.
No problem, I will.
Okay, thank you. So one question that I just answered, is it like post-traumatic stress disorder? Okay, PTSD. No, it's not. It's very different. It has not always, but sometimes a longer lasting effect because this is how the brain was shaped when children were younger. Is it a diagnosis? No, it's not a diagnosis. So you may see it, let's say you get an assessment for your child, maybe you'll see it in the assessment, but it's not a mental health diagnosis that is in the DSM as we're talking now. Okay, it may be eventually, but right now it's not. It's presented in other ways, okay? Not in the same way that it's presented here. Can children heal from complex trauma? I guess that's a question that we want to answer. Can my child heal? And I guess the best example that I could give you, like if I go to like I go skiing and I break my leg, maybe the doctor will be able to fix my leg to some degree, but maybe I'll be sort of limping a little bit for a long time, and maybe I'll have permanent damage from what happened. So it's kind of the same thing with complex trauma. Some children will have long-lasting effect from these early adversities, And some children, you won't see the impact as much. And there's many factors that will foster the recovery of children with complex trauma. But I would say that one thing you really have to remember, it doesn't fall 100% on the parents, on the caregiver to heal your child from complex trauma. There's many, many, many other factors at play here. And even in the best environment, ideal environment, some children don't recover the way we would like them to recover. So I want you to hear what I have to say in this presentation, especially when I get to the solution part, not as, okay, I'm not doing this, I'm not doing that, and like just get overwhelmed with everything else you have to do, but just know that, yes, we want to improve as caregivers, as professionals, but it's never going to be enough. There's the community that needs to help, and our children have their own journey as well. And some children will carry their wounds for a long time, or, it's going to be their life journey. Okay, so these are the impacts of complex trauma. And the way I will explain them today, I will explain them one by one. But you'll see how they're all intertwined. Like even the way the graph is usually presented is like there's so many lines in between, but honestly, I was just too lazy to do all those lines. I'm like, nah, let's keep it as is. But just think of, okay, for example, regulation of affect. So it's basically how you manage your emotions. And then you have behavior control here. So the way you control your behavior. So of course your emotions will impact the way you control your behavior. So while they're presented individually, it's extremely intertwined. And it's hard to know, oh, like I think it was like the mentalization here that was off and what happened today. No, it doesn't really matter. It's just making sense of why our children are acting the way they're acting and what they're struggling with. I'll give you a very, very typical case of someone who's impacted by complex trauma. So let's say Anna, she's 12. And by the way, Anna is fictional. It's not anyone I know, just so we're clear. We don't break confidentiality like that. But I'll go back to like Anna, okay? Anna is 12. She was previously exposed to drugs, alcohol, and her biological mother was under a lot of stress. She has difficulty with sleep, which strongly affects behavior. She has heart issues, and so far she's had 5 placements. And very often she was moved from her biological family to other placements because her behaviors were so intense that caregivers were not able to manage keeping her in their home safely, and they need to protect themselves and other siblings. So at school, she's really struggling with keeping friends, playing safely with peers. She's struggling with authority. She doesn't like to hear no, being told what to do at school. She also has learning disabilities, so she doesn't feel competent at school. She often feels excluded. Um, she feels like teachers are all like are on her back all the time, like they're targeting her more than her peers. She has a lot of difficulties separating from her caregivers, although she's really rejecting during daytime, but then she doesn't want to leave when it's time to go to school or to activities. So there's that attachment piece here that parents are like, what is going on? What do we do? So you see here, you can see how Anna has several impacts from her adverse childhood experiences, but they're all intertwined. If you feel like you don't really have friends at school, it's hard to learn, you feel like adults don't really have your back, you don't really want to go, it's a bad experience. But then at home, you feel like this tension because you want to be close to your caregiver, but at the same time, it doesn't feel good. Your alarm system is ringing when you're too close to your caregiver because you have attachment difficulties. So you feel unsafe quite often. And then add to this sleep issues. Children who have been exposed to drugs and alcohol, especially alcohol, more than 90% of them have sleep issues. So if you don't sleep, I mean, when I'm jet lagged, I'm a horrible person. So like just to add all those extra layers, it's hard. You know, you'll see hard behaviors. So we're getting now into some of the impacts individually of what you may see in your child. I would add that some of them you may be like, okay, but my child was diagnosed with autism, or my child was diagnosed with FASD, Fetal Alcohol Spectrum Disorder, um, or ADHD. Okay, so do they have that because of the ADHD, FASD, or did they have that from complex trauma? We will never know. Very likely you won't know. This is how the brain developed based on the environment. And when I say the environment, I'm talking about also the prenatal environment in which they were in. Okay, biology and somatization. What do we mean by somatization is sometimes people who have trauma have pain in their bodies. It's not necessarily an injury, it's just based on their trauma. So, for example, like bowel issues, belly pains, very common in them. Um, Under stress, maybe like jaw problems because maybe they're clenching their teeth while they're sleeping. Um, and sometimes it's really hard to know, I guess, as a caregiver. If you're a caregiver, you know what I mean. Like, is it like, okay, they have a belly pain. You cannot diss the belly pain, but at the same time, maybe it's the trauma. So, like, what do you do? We'll answer some of those questions. We know from research that children who have been, I don't want to say diagnosed with complex trauma, but have complex trauma, had many adverse childhood experiences, are at increased risk of autoimmune diseases and medical conditions like even diabetes, heart issues. So heart issues is actually more common if you've been prenatally exposed to alcohol, but it's also more common in children with complex trauma. What you basically have to remember is the brain development is altered. And sometimes it's so altered that you can even see if you do a scan or an MRI. Some parents, I get this question all the time, like, okay, what about we scan their brain and then we know which region is affected, so we'll know what to do. Honestly, it's useless. Sometimes the lesions or the alterations are so minor that you won't see them, but it doesn't mean it's not affecting or impacting the way they interact with the world or how they behave. And I'm welcoming questions on this. I think it's something that people really struggle with at times. Like, okay, like what does that mean here? Like, what do I do when this is happening and they complain about body pain? The sensory system is quite affected. The sensory piece, we also see with fetal alcohol spectrum disorder, it's no longer in the 10 domains for a diagnosis, but we see that quite a bit. And we see that the sensory integration problems, like especially in younger children, like being sensitive to noise, difficulties with filtering which noise I should be paying attention to. So you might be like, Alex, Alex, and then they are like listening to something else. And it's not that they're not hearing you, it's just the way they're filtering sound may not be appropriate. Being sensitive to touch, pain. So I'll give you an example. Something that is super weird to me is like some of them, you like very small touch, like this is very triggering, but like almost like a punch doesn't feel like it's much to them. So it's just like really dysregulated their sensory system or even the way they deal with cold or heat. Like I had this mom I was supporting it back in Vancouver, and she was outside with her baby, and I'm like, what's going on? You're just wearing a t-shirt, your baby's wearing a t-shirt, but look at everyone else. Like we're all wearing like big jackets. It's super cold for Vancouver anyway. And and she's like, I'm not feeling it. So see, like it was very dysregulated for her. Um, Lots of sleep issues, like I mentioned before. And for some, it's just that their alarm system is on all the time. Like, they're always on high alert. So it's really hard to fall asleep or stay asleep. And for someone with FASD, sometimes it could be that, but it could also be their circadian rhythm that is affected. So circadian rhythm is like your body sort of like routine, like, oh, I think I'm hungry, oh, I'm full, I'm tired, I should go to bed. Like day, night, like yeah, your body routine. And it's also ma how we manage sleep. Like when your body is like, okay, let's start producing melatonin here to go to bed, this may be off for them. Any other questions about this specific aspect?
There is a question in the chat mode
Okay.
from Kelly. Is there a benefit to know that their brain has been affected, even if it doesn't tell us any more beyond that?
I think you'll see in their behaviors that their brain's affected. Anyway, so we know it's affected. We won't know where exactly and how. Um, I'll give you an example. Um, so the frontal lobe here is often impacted in children with complex trauma. So, and what the frontal lobe will do, it's kind of like the break of like, oh, okay, maybe I shouldn't say that. Like, maybe I should use my filter and not say that or not do that. It's the judgment piece. Okay, what should I do in this circumstance? So you'll see it in their actions and their choices. But you don't need a brain scan to do that. What I mean by like the idea of a brain scan. So for example, even the research that they do for FASD, when they're doing MRI, they need cohorts, they need groups of people, and then they can compare. So, for example, children were born male or female, then they scan their brain if they were impacted by prenatal exposure to alcohol. Then they see differences because they're grouped, but it's so minor visually that they won't see it. We hear of those random cases where, they do something pretty extreme. They're like psychopath, they do a brain scan, they really see like regions of the brain that are quite impacted, but it's rare. Um, and doesn't mean it's really impacting the behaviors that much. Like, so for example, one of my son has cerebral palsy, his left side doesn't work so well, but his behavior is not that affected by his brain alteration, and they're actually um, a visual on a brain scan or MMRI or EEG even. I think another question came while I answered this.
Yes. Does a neurological developmental assessment fill in some of these blanks without a brain scan?
I'm not sure what they mean by neurological. How did you?
Neurodevelopmental assessment. Does it fill in some of those blanks without a brain scan?
Actually, I would say that's probably more helpful than a brain scan, unless your child has other things like epilepsy, for example. So of course, like if I answer the question based on like we're talking about a specific person, I'd say talk to the professionals around you. But generally speaking, I think anytime you can have a really good profile of your child, of like their executive functioning difficulties, adaptive functioning difficulties, and I explain those later. How do they learn? How do they learn best? What are the difficulties with even speech and language, their sensory issues? If you have a really good profile, you know more what to do. But sometimes you won't know the cause of why they have what they have. But it gives you a bigger picture of strength and difficulties. So it's equipping you as a caregiver. It's like, okay, where do I spend my energy? I think another question came.
We have a We do have a question. Um, and it says, you are describing my 15-year-old daughter, somatic pain constantly and alienates people, no friends because of her behavior. Yesterday, the VP at the school told her she's one of the two most unstable students at school. So they told her to stop coming to the office. What do you say to the school to help them understand? And our friend would like to send this video of our talk to the school because the school does not have as much resource, I believe. So what do you say to a school? And I believe you may answer this later on in your solutions deck, Maude.
I will, but I would say, and I never want to answer questions being too specific about one person, one family, but I will talk at the end more about how complex trauma is, we don't want to shame the child or shame the family of origin or shame the parents who are caring for them right now. We need as a community to care for these children. And community means, the school, the hospital, faith groups, relatives. We all need to sort of play a part in people's recovery. It's building a system that takes into account that some individuals have complex trauma, they're neurodivergent, um, and that it's being displayed through behaviors that are not appropriate, that can be harmful to others and to themselves. And yes, I think advocacy and just spreading awareness on complex trauma and what can we do, like having a trauma-informed approach it's crucial. And I also say that I think for professionals and schools, like I think most teachers are like, I want to teach. I don't want to deal with those behaviors. Like we're here for teaching. And so I think it's like also change for them to change the way they're looking at things, that for some of these kids, what they need in order to learn, it's the relationship. But it takes a lot of effort to develop that relationship with these children. Was there another question or I keep going?
Just in addition to the point from our friend, it's important to also include the point that her daughter was being asked to stop coming to the office because of her constant injuries. Back to your point about the sensory and the physical well-being.
Yes. Yeah. And it's hard to like, I think the point here too is that we may think, oh, it's attention-seeking behavior. But is it? Maybe they're really in pain. Like even if I share from my own life, I had a few traumas that, made me have shoulder pain. And at some point I thought, okay, I need to adapt my office, blah, blah. And I realized at some point, okay, in periods of stress, my shoulder hurts. I don't have an injury on my shoulder. Like there's nothing physical, but this is where I have pain. But it's real pain. It's not, I'm not making this up, so I'm not doing the dishes or something like that, right? And doesn't mean I'm not gonna do something about it. But now I know, like I used to go see my chiropractor, like physiotherapy, all this stuff. Now I'm like, yeah, maybe I'll do a little bit of that because it brings some relief. But I know I need to manage my stress better in these times of shoulder pain. Um, So if we put that to children when they have these kind of pains, it's like, oh, okay, maybe there's an emotional pain behind that. So how do we respond? Behavior control now. Most adoption, and I say adoption because we're in the adoption context here at Interwoven, most adoption and or there's a placement disruption of some kind, it's always because of the behaviors, because they've been dangerous to themselves or to others around them, parents, siblings, pets, other people who live in the home. Always. That's number one cause. And that's why we have the AFCCA program, actually. Some of the behaviors can be externalized, which means to other people, like screaming, hitting the walls, destroying property, all this stuff. And then internalized behaviors is more like self-injury, being extremely depressed, refusing to go to school. So these behaviors are more like some of them you will see, but you don't necessarily see them. It's towards themselves. And externalize is towards others. Sometimes you have children who do both. And in some children, it's very much like one versus the other. I'd say that for females, we see more internalized behaviors, like eating disorder, for example, like it's towards themselves than others. So, like I said, there's a risk of inappropriate and dangerous behaviors. And why? I wrote why because I think that's always a question that's on everyone's lips. Why do they act the way they act? Why do they make those choices? Again, it's based on their brain. In complex developmental trauma, the brain is altered. So I'm sure if you've done other trainings, we have an amygdala. The amygdala is like the alarm system. For someone who's been injured by people they were supposed to trust many, many times, the alarm system is ringing all the time. Or it's never ringing. It's not ringing enough. So some kids, I've seen kids like they were coming from an orphanage and I was looking at them from a distance and they're like this, like extremely hyper vigilant. Or some are just like, that side look like being really cautious. And others, they do whatever. They don't see danger whatsoever. Of course, this is something you might see in prenatal exposure to alcohol, but we see that too with complex developmental trauma. Like they don't see the danger at all. They're like, whatever, the worst has happened. It stopped ringing. They don't see it at all. And something that go back to the school question, see that the learning brain is not available while the child's in survival mode. So if your brain, the alarm system is ringing, that area of your brain that takes care of the learning, it's not going to be working as well. Or if you are under like tremendous stress, it's not going to be working as much. One other thing that I mentioned previously is the frontal lobe. The frontal lobe can be quite impacted by developmental trauma. So this is actually something that they're able to see sometimes in scans that they do where it's much smaller, and that's the break. That's the, ooh, don't do that, Maude. Don't eat all the bag of chips, like you don't need that many candies tonight. Like you're driving, one glass of wine is enough, like it's all these things. Or you know, maybe I shouldn't have two boyfriends at the same time. Oh, I'm 15, maybe I shouldn't date a 45-year-old man. But it's that kind of thing that you'll see that is impacted by an underdeveloped frontal lobe. Okay, emotional regulation, again, behavior, emotions, and cognition, it's like a triangle. They're all intertwined. They're all impacting one another. So emotional regulation, now borderline personality disorder, when they're younger, we don't call it borderline, but many of our kids will eventually be diagnosed with borderline personality disorder. That's basically like tremendous difficulties with managing your emotions. You feel it, like it's big, big feelings all the time. They can't manage. It's actually painful to some of them. And this is what we see, and this is how, like, it's often exploding, like their anger, their worries will explode into a behavior that is not often not appropriate. Or, let's say you're a 16-year-old girl and you really, really like this man. Everyone's like, oh, so many red flags. He's not appropriate to you. It's dangerous. And you're like, I really, really love him. And they're passionate, and their frontal lobe is not going to be like, we're going to put a break to this. They just keep going. Okay. Something else I would say is like, in adoption, attachment, we always say, okay, you need to be well regulated, so you're providing co-regulation to your child. Okay, this is coming from attachment theory where let's say I'm a toddler and I hurt my knee, I start to cry. So my caregiver comes, picks me up, and like I'm like, oh, okay, it's comforting. But if your parent is often scary and you hurt your knee, maybe you don't want to go see your parent. So you get placed to a new family and you're not necessarily rewiring your brain to go, oh yeah, that's actually a safe caregiver. Some kids have not been able to rewire their brain, so they're still not able to accept the co-regulation from the adult at school, from their caregivers, from siblings, cousins, anyone. And some are able to accept the co-regulation when it's someone they don't know as much. It somehow feels safer to them. Also, if you have severe emotional regulation, because that's the core foundation of a good mental health, safe relationship, good emotional regulation, you're very likely to develop mental health diagnosis, anxiety, depression, borderline personality disorder, narcissistic personality disorder. This is usually stemming from these kind of issues. Something else that I want to address is parents, professionals who say, okay, he's going from like 0 to 100, so I don't see it coming. The big problem with people with complex trauma, and this is the same for FASD, they don't go from 0 to 100 because they're at 90 all the time. So, you say, hi, why did you say hi like this? Like, okay, that's so man, maybe tomorrow I won't say hi. So you don't say hi because you're like, this is obviously a trigger. You don't say hi to me? Like, see, like, so anything can be a trigger to them. They're 90. So going to 100 is very quick. And we also know that going from, let's say, 100 to a little bit lower takes a lot longer to them. So it's always taking into account that, whenever a professional says, okay, try to see the triggers, sometimes it's good advice, sometimes it's not a good advice. If you feel like you're constantly walking on eggshells, everything is a trigger, it's just your child is always at 90, and maybe there's other strategies you have to use because it's not going to be helpful to try to see every single trigger in your child's life. And actually, this could lead to an over accommodation that we will talk about later. So when I do exit like this, it's just I have to be mindful of the time. Alexithymia is not very well known. Actually, I'll disclose that one of my children had that. He was from an orphanage, and he was told, don't feel your feelings, don't cry. No one would name feelings around him. You had to shut down your emotions and the feelings in your bodies that are with your emotions. If I'm stressed out, maybe I'll feel it in my body, maybe I'll get the chills, things like that, right? But people with alexithymia, they're not able to to say this is how I feel. And this is why some therapies are not appropriate for kids. So if you take cognitive behavioral therapy, CBT, now we have the trauma-informed one, but for someone with alexithymia, it doesn't always work because what CBT does, one of the things it does is, how did you feel? What were the body reactions you felt when this happened? They're not able to feel it. For someone with alexithymia, a very good treatment is occupational therapy, like going back to the sensory aspect of your body, feeling your body again, starting to name those emotions, starting with the core foundations of emotions, reading books, having caregivers, people around them, naming those emotions, the experience. And I'd say that someone with alexithymia, it's not just the negative emotions, it's also the joy that they're not able to feel. So, I remember like one of my children who had that, we made this incredible cake. It was so expensive, guys, like so frustrating. It's like, here's the cake. It's just like, okay, thank you. It's so frustrating, you just want to go, yeah, just be happy, because we're so happy. Um, yeah, so that's alexithymia. This one is not as well known. Okay, attachment and relationship difficulties. This could be a whole webinar in itself. I actually gave one just last week on attachment and prenatal exposure and how this is affected. So the core foundations of attachment is the baby needs to be soothed, comfort, especially when they're ill, hurt, or scared. This is usually when attachment happens. And the caregiver the adult in charge is supposed to be providing co-regulation to the child, comfort, and the child is supposed to accept the co-regulation and the comfort. Children who were in an environment that were unpredictable, sometimes the caregiver was there, sometimes he wasn't, um, sometimes or extremely rejecting of the child, um, being fully there and not there for a long period of the time. This could this could affect their attachment patterns. So they're secure. About 50% of the population has secure attachment, which means you trust others, you're able to recognize the red flags, you don't take things personally all the time, you're able to have a healthy relationship. And again, I'm strictly talking about attachment patterns in children here because adults is something else. An anxious ambivalent is the child who you would, it's really hard to separate from caregivers. So, for example, let's say there's an incident, it's getting dangerous. Professionals would say, oh, go to the bathroom to protect yourself. The child will follow you. Okay, I'm sure if you're a caregiver, you'll be like, yeah, I did do that. Okay, it's like I want to be close to you, but at the same time, it's very, very scary. I don't want to separate. And to an extreme, it's disorganized attachment. So it's not organized. Like sometimes they are extremely like anxious. They want to be with their caregiver all the time. They're extremely clingy. And then for another month, they will be extremely rejecting. So this is disorganized attachment. This is also something that people call reactive attachment disorder. That's when it's like it's going really badly. It's also a spectrum. It's not like, oh, I'm secure, oh, I'm avoidant. Very often, it depends in which environment you are, it depends with whom. So, for example, children are extremely avoidant of, let's say, the father, and with the mother, they're extremely anxious, in heterosexual couples. So, what you have to remember here, because I can't, give a whole 1 hour on attachment, it's like some of the behaviors will be attachment based because 100% of children with complex trauma have attachment difficulties of some kind. Some people say attachment issues. I prefer to say attachment difficulties because I feel like attachment is something that really can be built on. And it depends on what you're hoping for. For some children that are extremely avoidant, like closeness doesn't feel good, they thrive in certain environment. And if the caregivers are able to accept that the relationship's never going to be as close as they would like to, it's possible to have a positive relationship. And of course, there's treatment that you can do for attachment, like Dyadic Developmental Psychotherapy, ARC, which is attachment regulation and competency. These are really good treatment, but uh, something I'll warn you is if it's too unsafe right now in your home because of your child's behavior, you may start by something like polyvagal to regulate your own nervous system, recover from your trauma that you experience in your caregiving role, and then VR, nonviolent resistance, to bring back, hopefully, a safer environment so your child is more able to engage in attachment therapy. Attachment therapy is not always recommended at large. So, for example, what they do in the UK, very often they'll do NVR, stabilize the home a little bit, and then they might do attachment therapy. Because one problem that we see in attachment, like I'm such a big fan of attachment, I'm I have to stop talking about this because it's very, very much a passion of mine. But I'm just going to say this. You cannot force attachment on a child. Okay. And I feel like a lot of programs are like, do this, do that, and then your child will develop secure attachment. Not necessarily. And sometimes the recommendations are like, okay, what does your child like to do? Oh, they like to play school. Like they're the teacher, you're the student, whatever, but the parents hate it. This is not going to be helpful for attachment. If you feel like you don't want to be around your child at all, And they're scary to you because they've injured yourself or someone you love in your family. You need treatment and safety before you do that attachment piece. We also found that the philosophy around attachment is very westernized. So what's promoted, especially in the adoption culture, is one or two caregivers. Okay? It's like the parents. You're in charge. You don't have a lot of people around you when you adopt. This is what I did. Big fail. Like, wasn't a good idea at all. We need community. It's kind of like asking someone to climb the Everest alone. Oh, you two people, you're so competent. Just do it alone. No funding, no people to help you, or maybe from a distance they'll be waving or something. Some will be judging probably along the way, giving recommendations, but not helping you. We need others. We need bodies who understand. We need people to carry the load with us. We need other people to have safe, secure relationship with our kids and start young, especially if you're a child who has a neurodevelopmental disability, they will need support long term. So it's best to start early. So, and oftentimes the attachment piece, we see that more in the primary caregivers. And when there's a mother in the family, we see that more, even more towards the mother, generally speaking, not in every family, but generally speaking. Um, I was gonna say something else. Okay, so something else that I would also say, there's this thing called decolonizing attachment. Like I said, attachment is a very, very much a westernized concept. So we do need community. Most cultures have community to help them raise their children. And we need, maybe this is gonna sound like weird, but we need nature. We need spirituality. We need other things in order to co-regulate ourselves. Just an example, sometimes, like let's say after this webinar, I have a plan to, first of all, I'll probably eat, but then I live in the forest and I will probably go walk my dog in the forest. I don't need another human. Actually, I'm not going to need another human. I'm going to need nature to co-regulate. And some of our kids, they co-regulate with animals. Like, so you can think of like animal assisted therapies. They're really good for your kids. And not thinking just in like, what can I do myself for this child to regulate themselves? For some, it's their faith practice. When they pray, they meditate, all these things can actually help you as a caregiver, but they can also help your child to develop a better attachment. Okay, I'm just gonna look at the time again. How long do I have? Boop, okay. Mentalization. Can you tell me, Rondola, the time? Forgot to put my.
Yes, we're at 12:30.
Okay. Mentalization. Okay. Mentalization. I think I have a video on our YouTube page. We have a YouTube page called the Caregiver Series AFCA, AFCCA. And there's a video on mentalization, I'm pretty sure. Mentalization, it's your capacity to understand someone else's mental state, what their intentions, pretty much. So if let's say someone else says, oh, can I talk to you after this webinar mode? I might just be like, oh, I wonder why. Like maybe they need help with like their own PowerPoint. Someone who's been traumatized might think, I'm in trouble. What have I done wrong? See, like it's the intention that we place on someone else. Actually, I think maybe 95 to 100 percent of the cases that I've seen who have children who display harmful behaviors, they think that parents don't mean well most of the time. If the parents say no, they set a boundary, they don't think, okay, I'm not happy with this, but I get it, so I'll do that. Okay. My daughter who has like a secure attachment. And yes, she was adopted, but she's pretty much recovered from a lot of the harmful event that happened to her. And when I say, you know what, your bedroom's a mess, and I'm going to take your phone tonight, and I'm not going to give it back to you until you clean this mess, she will accept it because she's more towards secure attachment. and she knows I mean well. But for some of her kids who have not recovered, they have that mindset. You don't mean well. I cannot trust the world. And the difference between mentalization and metacognition, maybe you've heard in the FASD world, they talk about metacognition, is I understand my own mind. I understand why I reacted the way I reacted. So let's say my daughter at first would be like, what? You're taking my phone, blah, blah. And then later on, if she had good metacognition, she might come back to me and say, okay, I really freaked out when you said I could not have my phone because I was supposed to have a phone chat with this guy I like at school. See that she's understanding herself, her emotion. By the way, I'm making this up. It's not really what's happening for her, but just to give you examples. So it's thinking about your own thinking, your own feelings, and this is really impacted for someone who has complex trauma. I'm sure you're seeing it. You're like, this is so off. I cannot understand why they cannot go back to what they've done and say, oh, this is why I've done this or that. Or sometimes they're able to explain it, but it's pretty off. Like they would start blaming you when in fact it wasn't about you at all, or blaming someone else. And I'd say that yes, I did skip a slide in case you guys are worried. I'll go back to it. It comes back to the shame. Most of these kids have they don't see themselves as good people. So that's the difference between shame and guilt. If I have guilt, oh, I've done that, I feel bad, I'll make a man. I'll explain, okay, I'll explain my part. But if I have shame, so in my daughter's example, let's say she blew a gasket at me because of the phone. Um, if she felt guilty, she would come and explain. If she felt shame, maybe she will blame someone else. Well, I didn't have time to do my room because yesterday you asked me 5 things to do, so I didn't have time. Or my brother made a mess, or whatever. Teacher's fault. Or they will minimize, oh, my room is not that dirty right now. Your expectations are so high, it's crazy. Or they will hide. Maybe they will hiding, like it's maybe sometimes an extreme form of shame is the children who want to stay in their room, not engage with people, just playing video games, that kind of thing. That's of sometimes a shame-based behavior. So the system of meaning is how they make sense of the world, what they think of adults around them. Can I trust them? Can I trust my peers? If something happens to me, will they be there for me? And very often, some of these kids can feel like they can only count on themselves. Even if they have extremely committed caregivers, that's not the narrative they have in their mind. Um, Sometimes I compare it to children who have sharp music in their mind all the time, like, remember Jaws? That's how it feels like they're in survival mode all the time. So they're like, okay, I need to be on edge or on my guard all the time. And everything's it's feels like a fight. And even innocuous comments from the parents, caregivers, can feel like a big attack because their sense of self is already quite impacted. It's impacting their self-esteem, what they think of themselves. This one I won't spend too much time on it, but one survival response, we don't see it in everyone who has complex trauma, but some of them dissociate. So you might, call their names or something like that. They seem numb or not paying attention, but it's another level of like zoning out. Okay. And what they're trying to do is to not be in their bodies in the moment because it's too scary. And so that's sometimes a survival strategy that they have developed. Some of them are almost like conscious of it, and some of them are not conscious at all. And some therapies are actually designed to reduce the dissociation that may happen. The avoidance part is more like based on fear. So, for example, avoiding school, avoiding going to social events, avoiding to have positive relationship. That's another one. Sabotaging relationship. That's another kind of avoidance. So this one we did. Okay, and then we'll get to the strategies. The self-perception again, most of them have very low self-esteem. And again, go back to Anna from the beginning, who was 12 and with complex trauma. If she's struggling in school with learning, she feels people like laughing at her. Um, sometimes she blames herself quite a bit for things that are not even about her. And sometimes she should maybe blame herself, but she doesn't. She feels shame instead of guilt. So all these, if you look at every single aspect of the impacts of complex trauma, they are intertwined. So while I explain them individually, it's really hard to know which area is impacted. Some of them are maybe it's easier, but some of them is hard to make sense of. Is there a question? I think I saw like the chat popping up. Rondola.
There are a couple of questions here.
Okay, go
Um,
ahead.
so, understanding and empathizing with the cause of behaviors is very important, but should we just accept them without correction? Because if we correct every time, we never do anything but correct behaviors.
Okay, I love this is the best question of all time. Okay, next question because that's so important. And
Okay.
actually I'm going to spend the whole rest of the webinar on this question.
Okay. This is also related to
Yeah.
with the mentalization, how could you probably address a tough situation to ensure that they understand and don't feel like they're being attacked by the comment or question?
Yes, it's so related to the first question. Okay, next question, because I'll answer them at once.
This question is more of a logistics question for us. What therapy works for youth and young adults with CT, and where do you find it? How is it covered?
For CT. Okay, I'll address that one later too. Okay. Um, by the way, I do think I have a video longer on mentalization. If they're interested in knowing more about what to do for the mentalization part. But again, like, so I'll put the both questions together, okay? Our children with complex trauma, attachment difficulties, they will feel attacked by very minor comment. You may say, oh, like, could you put that in the dishwasher, please? I'm gonna start it soon. And it's like big blow up, okay? Like they feel attacked. You're always on my back, blah, blah, blah. Okay. Feeling attacked may be part of the mentalization problem because they don't think, oh, you're just thinking of organizing the home, keeping a clean home. You said that to older siblings before. They're just like they self-blame or yeah, it's just like the emotional regulation. Maybe that's something they felt already like at a 90 out of 100, and then you throw that comment, it just brings them over the edge. Okay. And I love the first question, which sort of address what can we do? And I would agree with most people who say it seems like we don't do anything. And it sounds like the message sometimes is like, you need to adapt your whole life to the fact that they have complex trauma, but that's not real life and it's not possible. I have 5 kids. Even if I regulated all the time, which I'm not, but let's say I was, perfect parent all the time. My kids have siblings who are extremely annoying sometimes and all have their sets of issues. So if I don't push them over the edge, someone else's will. Same at school, same in the community. So what do? We do provide accommodations, but we don't want to provide over accommodations, which I will get into soon. One thing that I would say is very often we are extremely child focused in our response. Okay, the child has this. We'll send them to speech therapy. We'll send them to attachment therapy, OT therapy, or occupational therapy. We're not thinking of what's the impact of this child being so dysregulated on their sibling, at school, on their peers, and on their caregivers. And very often the message that personally I hear, and that maybe I was sharing way more before I was an adoptive parent myself, is co-regulate yourself so you can co-regulate your child. Get some rest so you can be there for your child. But we're humans too, and recognizing that we have our own sets of needs and we need to take care of ourselves for ourselves too, not just for the child. Caregivers have many, many, many unmet basic needs. And sometimes starting with a list of what are my unmet basic needs as a caregiver? Is it sleep? Is it safety, peace, quiet? And sometimes it's going back to that and figure out how can I get the support I need in order to have that, to regain peace in my home, safety, to get some sleep. Very basic. Okay. And I know, like, I don't have time here to go individually. Okay, here in your family, this is what you can do. This is very complex. Okay. And this is not like, I'm not coming with at this with like, oh, there's so many easy answers. There's no easy answer here. So caring for the caregiver, having respite, I know it's hard to access sometimes, having restorative time, even if it's short. See, like after, personally, I have the capacity to go in the forest, regulate my nervous system, get some rest. Very minor things. And it's also the meaning making, the mindset. You know, when I adopted 30 kids in 3 years, like my mindset was like, I have to do as much as possible to heal them. And I was really forgetting myself. And it's always like, what else can I do? Can I do more? But this gets really hard or impossible. So the meaning making is the story we make in our mind. Do I feel like I'm the only source of support for my children? Do I feel like I'm the only hope for healing in my children? What's the story here? And this is going to impact your decisions, and this is going to impact your well-being as a caregiver. The peer support that we offer at Interwoven, when we ask parents, what's the biggest help that you've received? You know, I wish I could say, oh, it's me and Tanya, the therapist, but it's not. It's the peers. You know, talking to someone else who gets it, who's like, yeah, I've been through it. Like it's super hard. It's just that validation. So, you know, you don't feel like you're crazy. Because people they don't understand. If you don't go through it, it's really hard to figure out, you know, or make sense of it, of how it can look like to be an adoptive parent, foster parent of a child with complex trauma. Also, working on the communication skills. This is something that I've really worked on through the years with my kids, how I communicate things with them, how I also communicate things with other professionals around me. Like this can go a long way. How we say things to them. I'll get into that because that's kind of like the mentalization piece. And some clinical services are specific to the parents that can actually be very helpful. So Dyadic Developmental Psychotherapy, DDP, if you have a good DDP therapist, they will work with you as a caregiver before they work with the child. They will look at your own attachment style, look at how you can recover from the trauma you may have experienced as a child, but maybe even in your caregiving experience. You also have EMDR, so it's using your eyes to deal with your trauma because maybe you have trauma from your caregiving experience. I personally I do brain spotting, which is very similar. Maybe you've heard of that. Anything that's a narrative therapy too, I found is very helpful because you talk about what you think, how you make sense. Do you feel like a terrible parent? Because we're so used to looking at your child's behavior to assess our own parenting that you need to rewire that and go like, what do I do well? And not look at your child's behavior to assess your parental capacity. We at Interwoven, you may know NVR and polyvagal, which are also about caring for the caregiver, caregiver well-being. And yes, it will help the child. But I just want to make sure that my message also, you know, it's you also deserve safety. You deserve to sleep and safety in your home. The siblings sometimes we forget. So I and then VR, nonviolent resistance, which I'm a big fan of. We talk about rebalancing voices in a family. Very often, let's say there's multiple siblings, two caregivers. There's one voice that we hear most. It's the child who has the most difficulties. And everyone else is sort of like adapting their life around this person. What we want is to make sure that these children, and maybe sometimes these children have their own set of problems, especially in the adoption world, but anyway, just generally speaking, they need peer support as well. Find a peer who understands, uh, friends, big brothers, big sisters, cousins, uncles, whoever can provide that safe space where they can discuss what's happening in the family without shame. If there's a big incident, do they have someone to call or text? Can they spend time with other families to see what's happening in other families? Um, Sometimes we may even involve them in families, in therapies, sorry. But thinking of the sibling is very much crucial, and also making them aware of what we do to support the siblings. Because sometimes they feel like we're doing nothing because we don't do anything harsh in our parenting when we have children with complex trauma. Okay, so what can we do? Like the questions often, okay, do we let it all go? Do we all accept that this is happening? Okay, that's the question. One thing we often look at is occupational therapy for the child. This will really help with the sensory integration issues. Some of them have primitive reflex integration. Look it up if you don't know what it is, because I don't know how to go into this. But very often we'll see some results with occupational therapy, especially if they are trauma informed. If you can um, do occupational therapy jointly with a practitioner of attachment therapy, even better. Having an assessment and some diagnosis. Someone asked at the beginning, okay, is it good to have an assessment? Yes, like a good assessment, not just to have diagnosis. Diagnosis can be helpful for funding sometimes, not always, but just to get a sense of, oh, okay, like, okay, I'll give you a very specific example. A child I was working with, the parents were like, it seems like she cannot follow a routine. She forgets everything. And like making her backpack to like taking her pills, thinking of all these things. And I thought maybe she has adaptive functioning issues, and she did. So it wasn't on purpose that she was doing that. So yes, we were not doing everything for her, but we did set up an environment in which she was more able to thrive. And they had different expectations of what she was able to do. So DDP, Dyadic Developmental Psychotherapy, that's what I'm trained in. It's attachment therapy. The problem with it, I would say, is if there's not sa enough safety in the home, it's extremely dangerous for the caregivers and they don't feel safe with the child. Maybe it's not the right time to do attachment therapy. Maybe you need to have more safety in the home before you start that. I think I mentioned it at the beginning where in the UK, what they do is they do MVR and then they do attachment therapy once the parents feel safe for or safe with the child. Keeping, a lot of parents would say to me, it sucks because I cannot be spontaneous with my child. And it's true, it's hard. Like I get it. I've been through it as well as a parent. It's hard to not be so spontaneous because you have to keep structure, routine, predictability as much as possible. And it's hard. And that's why we need help. We need other people who are able to help us sustain that for longer. Having supporters, children with complex trauma. This is the key message here, by the way. Children with complex trauma will be more likely to recover if they have several safe adults in their life beyond primary caregivers. So we put a lot of pressures on primary caregivers to heal the child, but actually it's as many safe adults as possible who will help change their narrative that parents, adults mean well, they can be trusted, and it's through therapy and daily interaction that this could potentially be rewarded. Being as predictable as possible, also letting the child know our thinking. Remember the mentalization aspect where they cannot really figure out why we do what we do. Don't over explain, but as much as you can, explain why you do what you do. let's say to Anna, I'm going to take your phone tonight. I know you won't like it, but I'm taking it because you really need to clean your room. Maybe we know that she has difficulties with getting a start, initiate a task. So maybe we get started with her. Or maybe she has pictograms to help her. Or maybe she has a cousin who comes once a week to help her do her room, but she's doing it. Do you know what I mean? This is where we don't want to say we don't do anything. We let it go. Letting it go would be I leave her the phone because she's gonna have a tantrum and her bedroom is a mess and I do it myself. That's over accommodation. A proper accommodation will be like, how else? So she's able to do it individually. Or who else? Who else can support her in that? If the cousin comes, that could end up being a good time, a good relationship. It's not putting more pressure on you as a caregiver, and maybe she won't say no, and she's developed a better narrative around other people around her. Um, okay, I'll give you another example I give all the time. I'm conscious of the time too, but it really is about, okay, and I'm just going to present this. If you want to join our community as a caregiver professional, you follow this link and you will access tons of resources. So I'm just going to stop sharing while I sort of like end what I'm going to say. But one thing that you have to keep in mind is, and it's, I know it's hard to do because there's a lot of judgment out there, is the more people you can rally around your child and your family, the more you will foster the recovery. It will actually help your child not be too have too much pressure for attachment and for a positive relationship with you. It will give you more space. And they will also maybe change their narrative about people's intention. And it does take a lot of work, sometimes more work at the beginning when we start to do that. But I do feel like it's worth it, especially if you have a child with complex trauma and neural disability like autism and or FASD. They will need long-term support. So you may want to start that early and normalize receiving support from other parents or other adults um, for their daily life. I hope I'm answering this question. So, and we also, if you write to us for a question, we also have developed a self-reflection tool that helps you figure out, okay, am I accommodating my child because they need it, or am I over accommodating? So, for example, if they have sensory issues, they don't want to go on the plane, they're like, no, it's like, the smell is too strong. I don't think I want to go. Okay, we're gonna stop going on planes. No, maybe we'll go on plane, but we'll figure out a way for the person to feel safe. So maybe they wear their own cologne, maybe they wear a hoodie. Um, Same with having people over. We have parents who say, I don't want to have people over because it ends in a tantrum. That's an over accommodation. A proper accommodation would be, okay, I'm going to make sure that maybe my child is somewhere else. Maybe there's someone to, like a supporter who can make sure my child is safe. Maybe instead of having 20 people over, I'll have five. See, it's like making space to heal the trauma, but not having your whole life evolving around the trauma and over accommodating. I don't know if there's other questions about this. Um, it's almost the end. And again, I hope it answers some of your questions or it makes more like it's making sense of your child's behavior. But again, for very specific or even extreme situations, I think we all need professional help to figure out how best to support our kids and ourselves. Um, and yeah, and if the message that you're getting from today is like, if I can encourage you to get as many other adults in your child's life, do so as much as you can. And I hope this is helpful for you today. Thank you.
Thank you. Thank you, Maude. Just a couple of questions here that are left in the chat. Back to that one question about therapy. What therapy works best for youth and young adults with CT, and where do you find it? How is it covered? And I've got another one here. It's a comment, but also a question. These are some really great suggestions, but it is very challenging.
100%. Yes. When I present, I'm always struggling with, okay, I want to give you strategies. At the same time, I know they're really hard to apply. I'm a caregiver as well. I know it's hard. It's not easy. That's why we cannot do it alone. You're climbing the Everest, not a small mountain here. And as many supportive people you can have, the better it is. When it comes to therapy, I know that some people have funding through CAS. Many people don't have it anymore. Sometimes it's through the hospital, like CHIO, Sick Kids. Sometimes you can receive some of these therapies, not always. And some of them go private, and it's really expensive. We do some of it and Interwoven, but sometimes it's a shorter period of time. Like polyvagal is 6 sessions, and VR is about 12 sessions. But it's a good start. I feel like sometimes it gets you going for the next therapy. But I invite you to ask your peer support at Interwoven, your IPC, and usually they'll be more able to tell you what's available in your region and what funding is available depending on your personal situation.
Great. A couple of more questions are coming in. What are some resources once they reach 18? And
Hmm.
how do you find EMDR or didactic better?
DDP has, if you go online, DDP Network, you may be able to find a therapist. They have a registry. Or if you even type DDP Ontario, I'm assuming they're in Ontario, they can probably find someone. It's very popular here and it's popular in the UK. And the next one, what was the other question?
So, do you find EMDR or,
Oh, yes, same,
yeah,
same. A lot of attachment therapists are also trained in brain spotting or EMDR. And I found a lot more hospitals are trained in EMDR than DDP because it's also for any kind of like trauma that you had, not just complex trauma. Oh, and over 18, that was the other question. I was like, is there something? I think when it really depends on the profile of your child. I think we know more where it's going when they're 18. Do they have problems with the law? Are they still able to go to school? Is their problem more like the learning? Is it more emotional? Do they have new diagnosis? I feel like their profile is more clear when they're 18 to 20. There's still room for change, but I think at this age we know more what they need in terms of treatment and therapies. And some had time to make incredible progress. I've seen many kids with incredible progress. And sometimes it comes later. The brain develops until 25, 27, 28, and even older if they were previously exposed to alcohol and drugs. So that gives you time. And it's encouraging and not encouraging. If you have a 12-year-old, you're like, okay, I still have a long time to go. But I mean, like what I'm trying to say here is like a lot of change is going to happen.
great. And a few thank yous from Jennifer and from Sue, who found this very helpful. We've got uh, a question here from Avery. My child is 11. We talk a lot in our home and have always been age appropriate with their adoption story and his ADHD. He wants to understand what is happening to him and why he is the way he is. Is it appropriate to speak to complex trauma, what it means, and how we can help? I mean, obviously age appropriate, but curious as to how much to share.
Personally, my approach has never been that diagnosis based, other than the medical diagnosis that they have. I'm talking about my children, and even I'd say like the children I've seen in therapy. I talk about it in terms of the brain. So, because I want to also normalize it. Like, for example, my brain is like, if there's too much noise, it's not working really well. So I just say, like, there's too much noise. Like, my brain's not working right now. And I might say, for you, it's cool, whenever um, you need to ask a question. For you, it's like, it's very embarrassing because you might feel incompetent. This is basically because of what happened to you before, and then I might just like talk about it just like that, like a story. They said, it's this the adoption story, but also needs to be talked about normally. This is how your brain works. This is maybe your reaction, I think. Not in a shaming way. And sometimes giving examples to your own life. Like we don't all have complex trauma, but we all have been through trauma in our lives, and we all have differences in our brain, which leads to odd reactions or not functioning well in certain environments. So I think personally, I try to normalize that as much as possible and having this discussion so they can make sense of their behaviors and their reactions. Very often they're concrete thinker, so I might use stories like about animals if they're younger. And with teens, I might use stories of other people that are not really true, but I make things up. Or I might I was gonna say, oh yeah, say, oh, did you realize whenever we talk about this, I think you get stressed and you start, doing this with your hands or something like that. And they're like, oh, it's concrete, it's visual. They see it on their bodies. It's not something that's happening inside. So making it as concrete as possible, not stay in the abstract, might help. Is
Wonderful.
DBT effective? I saw
Ye-
that one.
Yes.
Yeah, well, with like all therapies, hit or miss. There's a lot of evidence base around DBT. It's made for borderline personality disorder. Personally, I'm trained in DBT. I have adapted some of it to people with FASD and complex trauma. I think the challenge whenever you have a child with complex trauma and prenatal exposure involve the caregivers. Some professionals don't, and that's when it goes really off. Like you cannot send someone with complex trauma home and say, do these strategies when you don't feel good. They're not going to do it. That's just reality. You need to involve people around them. Um, yeah, and DBT has a guide usually for parents, but again, it's like it's up to like the professionals to do it well and adapt it to the family situation. Yeah.
And we have one here, one last one. Oh, two last ones. Would DDP be a good therapy for a 10-year-old that disassociates all the time? When my son is at home, he pretends to be a cat and behaves like one, as to not have conversations or do what is asked of him.
Mm. It doesn't mean it's dissociation. Um, Sometimes it's like the therapist can help explore why he feels safe to act like a cat. He wants to be someone else, maybe, or something else, I guess. That's something that could be helpful. Some people like with FASD, for example, he's 10, emotionally and developmentally, he's maybe more like a 4 or 5 year old. And so a 4 or 5 year old who acts like a cat, behaves like a cat for fun is not necessarily abnormal. So, I think professionals can help you make sense of some of those behaviors. Is it avoidant? Is it just development? Is it dissociation? Dissociation is kind of a hard one to say, oh, this was dissociation, right? Um, but if you feel like the child often doesn't feel safe, then that's when you want to do maybe more trauma therapy than attachment therapy and train the parents to know how to respond when you see a survival strategy in your child.
And so our last question, I think, with links back to some of the things that you've talked about. How do you support a child who always takes things negatively due to low self-esteem or lots of shame? We often feel like anything we do garners a negative reaction, and whether we respond or don't respond, it was touched on in the presentation.
It was, yes. But there's other strategies. Like I will encourage this person to go look at the shame video and the mentalization video. I do talk about some strategies. I don't remember which one I gave, but I'll give one right now. You make 3 baskets. Oh, and we have a video on the basket exercise. Okay. You need to prioritize when you will address your child's behavior, when you won't. Okay. There's things with my kids, I'm like, okay, small basket. Anytime they do that, I will say something. Medium basket, sometimes I would say something like wear toque. Maybe it doesn't really matter if they're not wearing one right now. So maybe I won't say anything. And the big basket is like everything that me and my partner are like, you know what, we're not even going to mention it. Because if you have developmental trauma, very likely you do a lot of things that are not necessarily appropriate. So since you were very young, you're used to have people telling you everything you do wrong all day long. Can you imagine that? I can imagine being at work and having someone over my shoulder, do this, do that, you forgot to do this, you didn't do that right. Do you know what I mean? And that's what a lot of these kids have experienced. So you want to be careful in how you say it. First of all, state your intention. I'm telling you right now, and you've been making so many efforts, but just so you know, I would love for you to do that because blah blah. Blah. Say why, state your intention, that you mean well, and you prioritize when you will actually say something and when you won't. And if you have a partner, both partners need to agree on this and they can remind one another. I had this couple would say, let's say the mom's like, oh, like look at the countertop, blah, blah. And then this is something that this decided not to address right now with the child. So the dad would be like, oh, what about the basket upstairs? Just talk about the basket exercise. So she'd be like, okay, I need to calm down for now. And again, doesn't mean we're not doing anything. We are addressing some behaviors, but not all of them at once. They'll go crazy and we'll go crazy.
Uh, Thank you, Maude. In the question and answers, a very nice thank you, and lots of thank yous going out to Maude. So everyone here, we do thank you. It is our time, but we do thank you for holding space for us this morning. It was wonderful to feel your energy. Thank you to Maude, who has fantastic energy. And I know my pen has run out of ink because I've been doing a lot of writing. So we ask you please to have a look at our website a little later on today or tomorrow for follow-up on this presentation and where you can find it. And we appreciate your time. Thank you so much for being here.
Thank you so much for coming. I appreciate it and all the really, really good question. Thank you.